Welcome to part 2 of our podcast for our College of Nurses documentation standards. We're going to continue with abbreviations. We can only use agency-approved abbreviations because otherwise it creates confusion. Abbreviations are allowed because it helps to keep our charting shorter, and so it's easier to review, and a lot of medical words are really long. So abbreviations are okay, but you have to use only the ones that are approved by the agency. As previously stated, sometimes the clients are individual people and sometimes they're groups. And so when we've got an individual client, we need to have data about their health status. What assessments do we see? We need to have what actions were done. What is the plan of care for this patient? And how did this patient respond? So what are the evaluations or the outcome to the treatment? And we are going to be documenting both independent actions, the things that we can do as a nurse without any orders, as well as collaborative actions, the things that we do as a nurse that we can only do with a doctor's orders, such as administer IV fluids. And sometimes I'm going to be charting for a group, and I'm going to chart the same kinds of things. Assessment, though, of the group's needs, their purpose, their objectives, what approach did I use, and what was the outcome. So perhaps I'm going to have a group of young teenage boys who are wanting to lose weight because they're all overweight. And so that in my assessments, I might have them do a pre-assessment questionnaire to find out their BMI average, their age average, and what some of their goals and objectives were for coming to this program. And then I can tailor my program to better suit their needs, helping them to choose exercise and diet lifestyle habits when at home, when out with friends, when at school, in order to achieve a healthier weight. And I would detail what approach that I used, the different activities, the different information, the different handouts that were given. And then at the end, I could measure the outcome at the end of the session with, again, a knowledge feedback type of questionnaire. And I could also follow up within 6 weeks or so to find out what was their status. According to the College of Nurses, the person that provides the care is the person that needs to document the care. In exceptional circumstances, such as during a code, you may be required to chart for others. And if so, then you're going to include their name and their title and what they did or saw. But otherwise, whoever did the care is the person that charts it, and that helps to maintain line of accountability. So in our charts, we definitely have all of the subjective data that our patient is reporting. We've got all of the objective data that we have observed. However, sometimes there's information that comes from a third party. Perhaps it's the patient's roommate. Perhaps it's the patient's significant other. We're only going to include that information if it's relevant. For example, the roommate has observed the confused client trying to get out of bed, and in doing so, they slipped and fell and hit their head. And so now they're on the floor, moaning and crying, and something looks like it's misshapen and broken. And so in that case, it is relevant. And if it is the patient's roommate, then to maintain confidentiality of that patient, you're only going to identify them as patient's roommate and by the initials. Again, in case it gets cut off to law, but maintaining that other patient confidentiality. If it's a visitor, you're going to include the name of the visitor and what their role is, that they're the spouse, they're the child, etc. We also want to collaborate with other healthcare providers. And so a lot of times we will have group meetings with physical therapists, occupational therapists, speech language pathologists, as people are getting ready to go home, to make sure that everything is set up. And so that when these meetings are held, you need to include a record of what was said at that meeting. So somebody is going to be designated the recorder and identify who attended the meeting, what was the purpose, and what were the plans and outcomes from that meeting. As we stated, the College of Nurses mandates that everybody document the own care that they give. So if your facility has a policy about co-signing, you have to know why that they are co-signing. So for instance, when I was a student nurse and I was not regulated yet, any entry that I made into the paper chart of my client that I was looking after as a student nurse needed to be reviewed and co-signed by my instructor, who was a registered nurse. And so that's the reason for co-signing. When I worked at Children's Hospital of Michigan, when we were doing our drug counts at the end of the day for narcotics, those also needed to be co-signed. And that was for legality purposes, that the count wasn't done just by one person, that there was two people to witness it, to make sure that it was accurate. So always know why, if you are asked to co-sign an entry, what is the rationale, and make sure that the expectations are written clear. Let's say you get to the end of your shift and you realize that you've forgotten to document something that is significant that happened earlier in the day. For instance, your patient's been in bed rest for a long period of time, and you were instructed, or it was ordered, that we were to begin getting this patient out of bed, and you attempted to get them to sit in the chair, but when they were sitting at the edge of the bed, they became lightheaded and dizzy. So you just dangled them for a short time, and then you laid them back down to bed. You never made it to the chair. You would want to document that because it was ordered and it was the first time, so it's significant. So as soon as you remember something that is significant that you have forgotten to chart, you're going to go into the next available line, and right beside your date and time, you're going to write late entry. And you're going to include the date and the time of the event as well, and then to make your notation. So again, you're only going to do that if the entry is significant. The College of Nurses recognizes that sometimes paper charts might get lost, and sometimes electronic charts might get accidentally deleted. So once a facility recognizes, or a nurse recognizes, that the records have been lost, they may try to recall the information if they're able to. If they're creating a duplicate record, they have to do this, identify it as a late entry, and identify it as a replacement for a lost record. This way, if the original ever turns up and it's brought to court, now there isn't anything suspicious. If you can't recall the information, then you would need to state so in your replacement entry. Sometimes nursing care or advice is administered over the phone or via a computer screen and video chatting. And so if so, then you're not actually seeing the person, but you still are providing medical care, and so it must be documented. And you're going to use the same types of information. So what is the purpose of the caller? What is the name of the caller? What information did they provide to you? What information did you provide back? And the conclusion. If you're working at such a facility, chances are good that they've got standardized records to be able to document such care. Any kind of electronic records, so documenting via the computer, video conferencing, voice recordings, you need to follow the same core standards as for paper or manual documentation. So go back to the part 1 and look at your core standards. When you are signed in as an electronic record, your sign on along with your username is your signature. And so the company has to guarantee that other people aren't going to be able to guess your sign on. So the sign on, the usernames tend to follow a similar format, so they may be able to guess that. But you should be able to change your own password and reset it so that if you're thinking somebody else knows it, you would need to change it. And just to maintain safeguards, many facilities in healthcare agencies dictate that you change your password every 3 months so that people are, so that the information is protected, right? And you are protected that somebody isn't charting underneath your name. There is one different thing though with electronic charts. Now I can access anybody's data within that has ever gone into my facility. However, legally, you are not allowed to access any data except for the records of the patient that you're actually looking at. So that I can't go in to look to see how I saw my neighbor in the waiting room. I can't go and search their name and find out why they're here. I can't look up test results for a family member. I can only access the data of the patient that I am looking after. And they do monitor that. And fairly recently, in our own little city, that there were a lot of charges that were laid for people accessing data that they shouldn't. So, and of course, you should not delete it. This system is set out that you can't physically delete the whole thing, but you can modify it if you've made some errors. So this next section would be if you were setting up your own company and you were using computers to document. These are some of the things that you would have to build into your system. However, if you're working for your employer, these are the things that they have built in. They have to be able to maintain confidentiality and security. They have to give temporary users access, such as students. They have to be able to track their care providers. What are they looking at? What did they document? They have to be able to retrieve data and to be able to share data if it is permissible and it's required. And knowing that computers sometimes crash, they need to have a backup system that is accurate. And for all of us users, they need to have a support team, our IT team, to help us navigate when we need assistance. Maybe we can't get into the computer, maybe we've charted on the wrong patient, whatever. So our IT people are there as experts to be able to help us navigate and correct our errors. Please note that legally, clients are entitled to see their own chart because the chart is about them, right? However, the agency may decide on the method. At Children's Hospital of Michigan, when a parent wanted to view the record because they were the legal guardians of the children, they had that right, but they needed to make an appointment with the physician so that they could go through and to explain, because there's a lot of medical terms and medical jargon. So each agency decides on how to do it, but legally they are able to. Patients can also add information to their charts if they feel that the information is one-sided and not representing their viewpoint. In that case, the nurse would assist the client to add information. However, when in doubt, seek advice from your employer on how to go about doing that. But legally, they are entitled. As stated before, you are only allowed as a nurse to access the records of care of the people that you are actually caring for. Nobody else. You can't look at a neighbor's stuff. You can't look at family member stuff. You can't look at the fellow that you cared for last Christmas to see how things are going. And sometimes there are people outside of the healthcare team that are requiring access to the chart records. For instance, if you are part of a research study, or that the records are going to be, they're going to a court of law because of allegations of child abuse or something else. So whenever the records are going to be viewed by somebody that's not within the healthcare team, the client has the legal right to be aware and to provide consent, unless it's legally binding, such as in the case of abuse. Then they are still needing to be aware, but they don't need to provide their consent because the law overrides that. When in doubt, because you can be charged with violations of the PIPA Act, you need to seek advice from your employer. And that's the end of part 2 for our College of Nurses documentation standards.